We have the president here, Dr. Makkar just spoke. So I think, thank you, sir, for the kind words of introduction, and thank you to Dr. Vijayakumar for inviting me to be here in this important meeting. And today the topic that is given to me is about aging and diabetes, how aging affects the, has an influence on diabetes. And I'll briefly, because the time is very short, I'll briefly discuss about some of the pathophysiological aspects about aging and discuss a little about pharmacotherapy and choice of pharmacotherapy with people who are aging, particularly using management of diabetes during this speech. So as we know, diabetes is a growing epidemic and we are all aware of this. I don't have to go through that, but it suffices to say that we are having a huge burden of diabetes, and while the number of diabetes is increasing, the age of the population in general is increasing worldwide. And our country probably also, although we have a large amount of younger population, large number of younger individuals, but the number of people above the age of 60 is also gradually increasing. And today we have about 90 million people in South Asia. In our country already has about 80 million of this is from our country, and there are 7 lakh deaths happening because of diabetes every year. And if you look at the ICMR INDIAB data and we look at the age-wise prevalence of diabetes, age and sex-wise prevalence of diabetes, we see that in both men and women, the prevalence of diabetes is increasing as age advances. And so therefore there is clearly a need to understand that the fact that with increasing age, diabetes risk is increasing. And why does that happen? That happens because there are changes with aging. You find that there is an impairment of insulin secretion, the beta cell response to endogenous incretins starts coming down, there is reduction in insulin sensitivity at the level of the muscle, adipose tissue, there is and also there is increased beta cell loss which is happening, and inflammation is also oxidative damage is happening with age, and all these things are contributing towards the loss of beta cell function. And this is ultimately leading to sort of increase in glucose levels, in glucotoxicity, and there are several mechanisms by which beta cell damage is happening. You can see the list of all the mechanisms, that is the reactive oxygen species, the excess generation of free fatty acids from insulin resistance, obesity, the obesity also, growing obesity with increasing age. There is increase in the body fat percentage, is excess ectopic fat, as we were discussing. We had a beautiful discussion on ectopic fat in the morning by Dr. Krishna Sheshadri. So I think all these we have seen from there, that how ectopic fat induces inflammation and leads to the beta cell damage. And we also understand that if you look at another important concept that I want to bring in is of sarcopenia, because what we see is that with aging there is increase in fat and decrease in muscle mass. And that decrease, while we are speaking about the fat all the time, we need to focus on the muscle mass also, and we understand that with decreasing muscle mass there is a significant contribution towards inflammation and towards the oxidative stress. As you can see from this elegant data, this is from a Korean study which has shown that in subjects over the age of 60 years, prevalence of sarcopenia was greater in both men and women with diabetes than in non-diabetics. So clearly, presence of diabetes, increasing age, causes greater muscle loss and increased fat deposition. That is all contributing towards the development of diabetes. So the other important factor that has to be kept in mind is that apart from these factors that we have just spoken of, the comorbidities that are present along with diabetes are also important, and these are going to be coexisting in people who are older. So older individuals tend to have coexisting problems with cardiovascular disease. They have more of cognitive decline. They have other mental health issues in the form of depression. They may have other problems which may interfere with their ability to be mobile, and increased fragility fractures. Polypharmacy is therefore required in all these individuals, and therefore there is a greater degree of drug interaction that has to be kept in mind, and we need to understand these issues when we are trying to treat elderly people with diabetes. Now if you look at the incidence of the complications of diabetes also, what we see is that all the complications of diabetes we are seeing that are clearly related to the duration of diabetes. Apart from the glycemic control, there's a significant correlation with the duration of diabetes also. And as you can see in this slide, it is looking at individuals over the age of 60 and over the age of 75 years who had the highest complication incidence of cardiovascular disease, with be it heart failure or ischemic heart disease. And you had greater risk of these problems as age increases. And as you can see in the age group above 75, that is shown with the orange bars, you see that all these complications are much higher. And when you look at data from United States, looking at individuals over the age of 65, they looked at the prevalence of various complications, and again they clearly showed that there is a higher prevalence of these complications in older individuals. To add to this, we have the factors like cognitive dysfunction happening with age, and also mental health issues coming in. So these are all going to add on to the problems of managing diabetes in older individuals. So therefore there is need to keep all this in mind and design pharmacotherapy which can be simplified, and also with the idea of reducing the risk of hypoglycemia, which is a major risk factor for precipitating cardiovascular disease also. So these are things that have to be kept in mind. So what should be the optimal target in older people? That is a matter of great debate. You can see across different guidelines there has been a great debate on what should be the ideal target for older individuals. Should we keep them at a HbA1c target of less than 7%, or should we look at flexible targets? This is what has been the discussion. As you can see in the slide, ADA has proposed less than 8 as a good target, but there's a level C evidence. We don't have very good evidence to say that we should reduce the target, be less sort of intensive in terms of our glycemic control. AAC also, which is otherwise looking at less than 7, less than 6.5 also, speaks about seeing that we optimize that and see that we don't have hypoglycemia, are able to achieve that with low risk of hypoglycemia. And we have even enough evidence from the ADVANCE and ACCORD study and the VADT study, which was looking at elderly individuals. We know that achieving a target of less than 6 or less than 6.5 is not going to bring about the benefit. There could be an increase in mortality because of the risk of hypoglycemia. So ADA has therefore brought about this, has put forth this chart where they say that the target should be individualized based on the presence of comorbidities, the risk for hypoglycemia, the age of the individual, the life expectancy which is there. So all these are important points which have to be kept into consideration. Another important point I would like to highlight here is that we have now newer understanding about the clusters of diabetes. And in these clusters, what we see is that there is one category called as a mild age-related diabetes, as you can see, which was cluster 5. And even from our country, the data from our country, from Anjana and Dr. Mohan's data, we have evidence that mild age-related diabetes, which contributes to about 35.8% of patients with type 2 diabetes. These are older patients. They have higher HDL cholesterol levels. They have fairly preserved C-peptide levels. They have milder diabetes, and they are at lower risk for complications. So in such people, the focus should be towards having a less stringent target, because ultimately our goal is to prevent the complications, and if they are at a lower risk of complications, we do not have to be very aggressive in such patients. So this is something which has to be understood, and we need to optimize the targets in such individuals. And as we have said that the choice of therapy should be individualized particularly in an older person with all the comorbidities and the other issues that are there. We should probably look at all the person-centered characteristics, the comorbidities, the clinical characteristics. So while we are speaking about older individuals, there are a group of individuals who are older but whose biological age may not be as much as the chronological age. So such people, we don't have to be treating them like the other older people who are actually functionally not as good as their peers who are maintaining a good functional status. Their biological age is lesser, and they need to be treated appropriately so that they are given a good quality of life, because ultimately we are looking at a good quality of life and striking a balance with the risk of complications, trying to reduce the risk of complications. And therefore, the use of this, this chart, this understanding about this shared decision making and assessing, individualizing care is very appropriate in the elderly individuals. So we have different pharmacotherapy available. Today we have 7 different classes of oral drugs for the management of diabetes, right from metformin to the SGLT2 inhibitors, the GLP-1 analogs, the DPP-4 inhibitors, all those are listed here. And the challenge is to make the rational decision based on the evidence available and looking at the person's specific characteristics that we are speaking about. And these are some of the points that may be taken into consideration. As we said, we are speaking about the older individuals. So clearly, we are looking at other characteristics, like looking at his glucophenotype, looking at his cardiovascular health, looking at the risk of hypoglycemia. If they have a high risk of hypoglycemia, we need to be less aggressive. If they have a fairly well preserved risk for a lower risk for hypoglycemia, there we could be a little more aggressive in terms of providing them a good quality of life. So these are the considerations that we need to keep in mind. And so it's not just treating diabetes, we need to provide a holistic care in such situations, consider the comorbidities and tailor make the therapy as per the individual requirements. So coming to individual classes of drugs, metformin is a good choice, but we need to keep in mind that when the GFR is coming low, coming below 45, we would try to reduce the dose of metformin to about 1.5 grams per day. When it's coming down to less than 30, we would try to reduce stop the metformin. And also keep in mind that we may need to look at the risk for ASCVD and then look at adding on SGLT2 inhibitors or GLP-1 analogs. GLP-1 analogs may have a limitation of being very highly, the cost may be a major issue in treating older people. We should keep that in mind also. When we are treating older people, we should try to provide them medications which are appropriate for their the cost also has to be a major concern in such people. So, and then we are looking at the SGLT2 inhibitors. If you look at the real world data or the clinical trial data, we have clear evidence that SGLT2 inhibitors fare well in terms of preventing heart failure and also preventing progression of CKD. So these are drugs which should be kept in mind. But only thing is that we should keep in mind that they have a risk for increasing the risk for genital infections, orthostatic hypotension, dehydration are issues that have to be kept in mind, because many a time hydration is a major issue in older people. So, and when you look at gliptins, they are a particularly well suited class for older individuals because of the fact that they have very low risk of complications. We have data from studies like the TCOS study for sitagliptin or the long-term trials of linagliptin. All these provide a lot of evidence that they are the very safe drugs which can be used in older individuals because they have a very low risk of hypoglycemia. And we have specific data evidence from large trials done on older individuals itself and with the use of gliptins, and all of them have shown that they are a particularly suited class of drugs. Now the major issue should be to prevent hypoglycemia, as has been adequately addressed even in the standards of care given by various organizations, ADA, or look at the RSSDA recommendations. Also we have a special mention about being careful in elderly in terms of preventing hypoglycemia. And we could use tools like continuous glucose monitoring can be done, CGM can be done, particularly when we have a risk of, we see that there are wide fluctuations in blood glucose levels. Repaglinide and agents like repaglinide, acarbose can be a good choice in people who have, older people who have got particularly postprandial hyperglycemia without causing them increased risk for hypoglycemia. Then the appropriate dose of statins should also be used. We should not forget about addressing the cardiovascular risk and the renal risk, and use appropriate dose of statins. Avoid combination of statins and fibrates because they do not improve the outcomes, but they may increase the risk for myopathy in older individuals. So this is certainly something which has to be kept in mind. We need to sometimes de-intensify treatment also in elderly people, where we see that there is probably no great benefit of putting them at a high risk of hypoglycemia without any additional benefit. So these are things which have to be kept in mind. And one important aspect that we have to keep in mind is also to improve the adherence to treatment. Compliance to treatment is a major issue, which can be a problem because of cognitive dysfunction, because of pill reminders and apps for pill reminding, or even providing boxes for appropriate pill counting. All these are important issues that has to be kept in mind. Finally, I would conclude by saying that older individuals with type 2 diabetes, management of older individuals is complex, and there are several issues that have to be kept in mind. The comorbidities that are there, the polypharmacy that is required, and the fact that there could be a higher risk of hypoglycemia, understanding the cognitive aspects and all other pre-existing comorbidities has to be kept in mind, and to provide a good quality of life with low risk of hypoglycemia and avoiding the complications as such. So with that, I would conclude, and thank you all for the patient hearing, and I would be happy to answer any questions.